I'm Norm Thurston, Executive Director here at NAHDO. I see a few names on the attendee list that I don't recognize, so allow me to just say hello and welcome to our NAHDO Hot Topics webinar for July. Today we've got an exciting lineup to talk about different aspects of dealing with provider data, so healthcare provider data. So we're excited to have you with us, and I'm going to go ahead and introduce our presenters. I'll just introduce them all at the beginning, so we don't have to take time in between. So we have with us Robert Richards, who works for Milliman MedInsight, and he'll provide some initial observations about provider data at the beginning, relating to the larger landscape of provider data sources, challenges, high-level solutions, and et cetera. Then we'll have Angela Taylor, who is from the cabinet, Kentucky cabinet for, I'm drawing a blank. Charles, you're gonna bail me out on this one. I always call it the Kentucky cabinet, but so Angela Taylor is a data expert there in Kentucky. Jillian Ryder will be then talking to us about her observations from Virginia's perspective from VHI, and then Ashley Storms from CHIA in Massachusetts. And then at the end of those, we will have times for audience Q&A. And so if you have questions, just go ahead and put them in the chat as we move along, and we'll gather those and we'll have a discussion at the end. So with that, I am going to go ahead and turn the time over to Robert. If you want to take yourself off mute, and then you should be able to share your screen. If not, let me know and I can share it from this side.
Sure, thanks, Norm. Can everybody see my slide?
Yes, looks good.
Great, thanks. As Norm announced, I'm Robert Richards. I'm with Milliman MedInsight. I specifically work on our data products group, worked a lot with provider data over the years. I'm excited to be with you today to talk about, as Norm said, the high-level landscape of provider data, use cases, challenges, and opportunities. So to start us off, I'm going to first raise the question: what is claims data, or what is a claim? When I say that, most of you here, given the kind of group we're in, you kind of know what a claim is. It's a record of a service that was provided to a patient on some date by a provider. It was provided for some reason represented by the diagnosis, and then there's payment amounts and things like that. Fairly standard data concept. When I ask what is provider data, that's a bit less clear, a bit less standard. We can say that it's data about providers, including their identifiers such as NPIs, names, etc., their location, where they practice, specialty, the organizations that they practice under, or their affiliations with other providers. That's pretty broad, and as you can see from the list of examples I've got here of where do you get provider data, it looks different in a lot of cases. It's not quite the same as a claim is pretty well understood across data sources. So you can see here a bunch of different examples. This may not be an exhaustive list, but these are some of the places where you can get provider data, at least some of it. Not all of these data sources have the same kinds of information, and certainly not all of them are structured the same way. And so that will lead to naturally a lot of questions and both challenges and opportunities that we'll talk about. So what do we do with provider data, or what can we do with it? So there's two major buckets that I've identified here that are relevant to this group for sure. So on one hand, you've got your sort of routine operational use cases. These are things that are recurring. You've got rosters, directories, credentialing systems, et cetera, Again, maybe not an exhaustive list of examples here, but things that are going to come up regularly. Often in these situations, you have complete or a pretty high level of control over the data collection, the structure of the data, how you're defining things, because these are sort of mandated data collection efforts under the programs that you're working under. Now, with that control, you also get to work through all of the challenges that come with collecting and constructing this kind of data. On the other hand, you've got your more one-off analytical or strategic kinds of use cases where there's some hypothesis that you're testing or some impact that you're studying. Certainly in economic modeling, if you're talking about supply and demand, provider data is the supply side of healthcare. So provider data is really important to that. In these cases, you often have to are limited to what's available to you, but then on the other hand, you have the flexibility within available data to sort of construct an analysis data set that is going to meet your needs. So with that, and in either use case, whether you're designing the data set to be constructed or whether you're evaluating data sets that are going to be used in your analysis, there's a few key things to consider. So the overarching question here is, why does the data exist? What is its primary purpose? And you can sort of use the answer to that question to map down to these more detailed concepts here. So for example, with universality, what providers are in or out of a given data set. So NPES, the reason NPES exists is to track individuals and organizations that are authorized to handle protected health information. And that means that every provider is going to be in the NPES data set, regardless of how they bill, regardless of what programs they participate in. It's just kind of a key feature of any provider. On the other hand, if you take 340B data, for example, that data is going to be limited to 340B participants, obviously. With something like claims data, even if you had all of the claims data, you might not necessarily have all of the providers, and that's going to depend on the billing patterns. Again, why does claims data exist? It exists to facilitate fee-for-service payments. So direct primary care providers, for example, would not be included in claims data. So why the data exists, or what its primary purpose is, really informs universality and really all of these kind of concepts here. So the granularity or structure of the data, what's included, how timely it is, how accurate it is, and even whether you can access and use it or not. So on this slide, this is just kind of mapping our use case at Milliman with provider data. The one that I've laid out here is building our provider registry product. And I'd be lying if I said that we had this framework mapped out in advance and that we asked all of those questions ahead of time. But this is a representation of the kinds of questions we ended up asking in developing our provider registry data set. Our goal was to build a comprehensive data set for provider market landscape analysis. We wanted to be able to track providers geographically and over time, tie them to the organizations that they practice in. And so we had to make some decisions about the kinds of data that we use, the kinds of methods that we use to construct that data. And so we ended up thinking about these concepts of how universal is the data, how are the input data sets structured, how are we going to communicate uncertainty in our methodologies and the sort of uncertainties or potential inaccuracies in the source data. Things like that. So That's just all of that is just a high level overview, introduction to tee up for you the presentations of my co-presenters today, who are going to, as Norm said, share with you their experiences working with provider data. And Norm, who are we passing it to next?
Yeah, great. Thank you, Robert. So next we're going to hear from Angela Taylor, who is from the Kentucky Cabinet for Health and Family Services and the Office of Data Analytics. So Angela, if you want to turn on your camera and take yourself off mute, we are ready for you.
Hi, good morning, good afternoon. I think it's afternoon, isn't it?
For most of us, yes.
For most of us. Okay, I'm not going to talk to you much about the actual provider data, more how we at Kentucky use the provider data to create our provider directory, our public-facing provider directory, to comply with the CAA requirements. I know that many people here are from the States and probably could have done this presentation as well and maybe even better, but Norm asked me because I guess I'm one of the cool kids, so that's why I'm doing this for you today. So many of you may know already that this is the basics of what was in the Appropriations Act as far as what needs to be on the provider dashboard for the public. So we are required to maintain an online provider directory that is managed by the cabinet, not by the MCOs. And then we needed to include these new data elements, which are languages spoken by provider staff and skilled medical provider, if they offer telehealth, if they're accepting new patients or new CHIP patients, what cultural capabilities that they offer, and then if they have physical and communication accommodations. We have to ensure that the information is accessible, accurate, and user-friendly for beneficiaries. The accurate part is always the hardest part because we all know how provider data is. And then to implement processes for verifying data accuracy, including provider attestations. So one of the most interesting things that I found about this particular rule is the 12-month rule. And so who's in and who's out, like who can be presented within the dashboard. So states must include only providers who are enrolled with the state, obviously, because we're looking for people who take Medicaid patients, and that they have billed or seen a member within the last 12 months. If a provider hasn't billed in over a year, they're not required to be in the directory, even if they're still technically enrolled. And why this matters, because it helps create an active provider list. So I'm sure many of us have looked at or studied or read information about ghost providers. So hopefully this will eliminate some of that problem. So what did we need to do at Kentucky? There were a couple of things. So the Kentucky Medicaid Partner Portal application, which I'll, for future of this presentation, refer to as MPPA, they needed to collect the new data fields. So those online provider portal applications had to be changed. And then the provider data has to be sent monthly now to the Office of Data Analytics. That's me, that's our team. And then what did we need to do within the Office of Data Analytics? We needed to link the data to the Medicaid claims because we have to see if they've billed for a member within the last 12 months. And then we had to develop a public-facing tabular dashboard. We initially created this dashboard long before it was due. The due date is July 1st of this year. We met ours by, I think we went live on June 20th, so we were able to meet that, but we actually had it ready back in January. The MPPA fields weren't available, so we did this, what we thought was kind of a cool thing, and built these proxies. So things like languages that were offered, we based those on the preferred languages of the members that the provider saw. So if you, let's say you spoke Spanish and you wanted to look for Spanish, we didn't have whether or not that provider spoke Spanish. So we said, hey, have you seen a large number of Spanish speaking members? So we tried to do that. The Department of Medicaid Services wanted to wait until all of the MPPA data was available. So we had to do a little bit of changing. We had to take out all the proxies and ingest the new MPPA data, and then redesign the dashboard to reflect that data, those new fields. So there were some issues with provider data. I'm sure we all are aware of these. The first and most confusing for our members is that the provider type is self-reported. So sometimes they don't choose their specialty types or their provider type accurately when they're filling out their data in the provider portal. So like a dermatology clinic wasn't listed under dermatology. Some of the provider names were pulled from fields. Again, the providers get to put that in. It's free form type. So there are typos and there's inconsistent formatting. We in ODA needed to ensure that we were getting the correct mapping. We got a few fields that we thought were one thing and were actually something else. So we had to make sure that all of our mapping was right so that the provider dashboard showed the accurate information. And then the specialty fields are too granular. So the provider types, like let's say for instance, physician, can have 10 different specialties. And it's difficult to understand what specialty you specifically need, especially maybe for a layperson who doesn't understand what those specialties are. So this, I am trying to make a joke up here. It started as a dashboard and now we're in exploratory surgery. The problems here are that there are tens of thousands of providers. There are over 60,000 providers enrolled in Medicaid in Kentucky, and I'm sure it's just like that or bigger in larger states. But to meet the CAA user needs, we had to add a lot of filters. So you had to be able to search on lots of different things. So now the users are experiencing frustration with how many filtering options that there are. And then of course, that has made the dashboard rendering super slow. This is what the dashboard looked like when we went live on June 20th. There are 8 filters up at the top. You could search by the provider name and you can select a distance. So generally, like you would put in your zip code of the local area, maybe where you live. Mine's 40509. So then I could put that in there and then I could see how far out I wanted to go. And then if you click on the more info, it would tell you more information about this specific provider, including the languages and the accommodations and things like that. Because of the Department of Medicaid Services wanted additional filters, we're trying to redesign this a little bit, and it's just become a little bit overwhelming because now you can search on all of these options, and it just makes the dashboard a little bit crowded. And again, all of these dots are providers, so there has to be, all of that has to be rendered every single time you change a filter. And part of this process too was getting our providers re-geocoded as accurately as possible. So hopefully that's all working well. And then of course, in the future, we want to improve the quality from the MPPA provider portal. And that has nothing to do with MPPA itself. It has to do with the providers and how they input their own data. So hopefully we can do some quality checks and they can reach out to providers and help and get their data input more accurately. And then we'll continue to refine the dashboard for usability and efficiency and effectiveness. And then of course, our goal is a tool that actually helps members find care. That's my presentation for today. So if you have any questions, I'm happy to answer. Also, if you do know me, many of you know that I'm a fan of bad dad jokes, so I put one here for you.
Great, thank you, thank you. All right, our next presenter will be Jillian Ryder from VHI. Jillian, go ahead.
Thanks, Norm. Can you see my screen?
Yes, that looks great, thanks.
Okay, thank you. Hi, everyone, great to be here. As Norm said, I'm Jillian Ryder, and I am the Data Systems Manager at Virginia Health Information, or VHI for short. To give you a quick snapshot of who we are, VHI is a small nonprofit public-private partnership that's been supporting statewide health data efforts in Virginia for over 30 years since 1993. We're a small but mighty team of only 18 people, yet our work spans a wide portfolio, including key programs like the Hospital Discharge Database, the All-Payer Claims Database, and the Health Information Exchange. The Hospital Discharge Database has been part of VHI since the beginning, and we launched the APCD in 2012. So compared to other states, our programs are relatively mature. That said, we operate with limited capacity. Of our 18 team members, only about a fourth of them directly support these two data programs. So keeping pace with growing demands can be a challenge. Before the APCD was up and running, our statewide data capabilities were mostly limited to inpatient discharges. The APCD was designed to bridge that gap, essentially by enabling outpatient comparisons at the provider level. There was and still is a strong interest in analyzing data at the individual provider level, but as many of you know, claims data has its own complexities, and turning it into consistent, meaningful insights is no small task. To help navigate those challenges, we work closely with Milliman, our APCD data vendor. Together, over time, we've done continual validation of our data quality, including provider information. A major piece of that is name standardization. We look at text strings to identify patterns, merge duplicates, and link every NPI from claims data to the most recent record in the NPES registry. For individual clinicians, we use first and last names straight from NPES. For organizations, it's less straightforward. Instead of the organizational name, we often rely on the other name or DBA fields to create display names that resonate with our users. Take One Health System as an example. If you were to do a direct pull of the organizational name from NPES, all of its facilities are generically listed as Sentara hospitals. Not only until you drill down to the DBA field that you find the specific provider location. The reality is provider data is more structurally complex than most of our users realize. Facility and professional claims are hard to separate cleanly, and on professional claims, the same individual is often listed as both the billing and servicing provider. Most users of our data also are most familiar with provider names, not NPI, which adds another layer of complexity to how that data is presented and understood. In Virginia, we also face internal constraints around data accessibility. Specifically, users must obtain approval from our data release committee to access provider identifiable information. For those who are interested in provider level insights, but not the identity of individual clinicians, we've worked with Milliman to create masked provider IDs. These allow users to conduct in-depth analyses while maintaining that provider privacy. Two projects in Virginia have made particular use of provider data from the APCD. The first is Smarter Care Virginia, an initiative spearheaded by the Virginia Center for Health Innovation focused on reducing low-value care, which is medical services that offer little or no clinical benefit, such as performing imaging for uncomplicated low back pain. Through this project, we used Milliman's health waste calculator and partnered with 6 health systems and 3 clinically integrated networks to pinpoint and address these practices, ultimately supporting more effective patient care across the Commonwealth. As part of this work, we generated reports tailored to each participating organization using the provider rosters they shared with us. Initially, it seemed like a straightforward assignment. However, the initiative spanned multiple years, and each organization just submitted a one-time roster. That created real challenges at the end when we reached the evaluation phase to determine the impact of the intervention. By then, the provider rosters were outdated. Some clinicians had moved, retired, or changed affiliations entirely. Since our analysis focused on provider performance at the system level, and NPES doesn't include organizational affiliation, we had to get creative with attribution. The process required several steps. First, we linked provider NPIs to CMS's facility affiliation database, which identifies each physician's affiliated facility using their CMS certification number. From there, we then mapped those facility IDs to the ARC compendium to estimate physician counts by health system. Even after all that, rolling up NPIs into health system rosters was not seamless. The final numbers came in higher than expected. Fortunately, VHI maintains self-reported totals of employed physicians across Virginia health systems, so we were able to do a side-by-side comparison, which helped us understand where some of the differences were coming from. In many cases, providers had been attributed as employed, when in fact they were affiliated through clinically integrated networks tied to a given system. These variations reflect differing definitions of workforce composition. Some health systems report based strictly on their Virginia footprint, while others include clinicians from their larger national networks, like HCA or Bon Secours Mercy Health, which can significantly inflate the apparent totals. The second project is Health Landscape Virginia, a platform created in conjunction with Virginia Commonwealth University and the American Academy of Family Physicians, which helps users explore health outcomes and social determinants of health across the state. One key focus area within the platform is primary care, specifically the local level distribution of primary care providers. To identify primary care physicians, the project followed a multi-step approach using the APCD. First, they determined which physicians were actively practicing by checking for NPIs linked to at least one claim in the APCD during the study year. Next, to pinpoint those working in a primary care capacity, they included providers who either had a family medicine taxonomy code or had submitted at least 10 wellness visit claims over the same period. While wellness visits are a key part of primary care, they only represent a portion of the services primary care physicians provide, and using this method potentially underestimates the volume of those providing primary care. Future efforts could benefit from a more comprehensive set of indicators that better reflect the full scope of primary care. It's also worth noting that Virginia has made notable gaps in APCD coverage, or has notable gaps in APCD coverage, since a good chunk of our population includes those federal employees and active duty military. When combined with other populations generally excluded from APCDs, this missing data represents a significant portion of our state's healthcare landscape, making accurate provider distribution analyses more challenging. So with that said, provider data is complex and messy, yes, but that's okay. We all came to that agreement at the networking sessions in Austin back in May, but it's worth acknowledging, don't let imperfection paralyze the work. Instead, embrace it, because meaningful work can still happen. We know provider attribution can be challenging. Naming conventions vary, data sources conflict, and structures are rarely uniform. But that's why it's so important to address the imperfection directly and be transparent. Document your decisions, and most importantly, use footnotes, because they are your best friend. They're not just for academic purposes, they're strategic, and they allow you to preserve nuance without bogging down the core message. And while methodology matters, so do relationships. At VHI, because we are so small, that is what makes collaboration so essential. So lean on your network, your data vendor, partner states, and organizations across your own state, because sometimes the best answers come from a quick call, shared workaround, and learning from others who have faced the same hurdles. All I got. Thank you.
Jillian. Our next presenter will be Ashley Storms from CHIA in Massachusetts. So Ashley, if you are ready, go ahead and take yourself off mute and turn on your camera.
Hi. And Norm, it was only during that last presentation that I realized that all three of the states presenting today are from Commonwealth. So I don't know if that was intentional, but it's a cool trivia fact.
Yes, we did that on purpose. We only believe in Commonwealths. We don't believe in states. So purely coincidental, purely coincidental.
Okay, and everyone can see my screen now?
Yep, looks great.
Perfect. Okay, so hi everyone. My name is Ashley Storms, and I'm from the Massachusetts Center for Health Information and Analysis, which I will refer to as CHIA from now on. And today I'm going to share 3 types of provider level analysis and the different data sources that we've used to address them. But before we get into that, a little bit about CHIA. We were created in 2012 as an independent state agency to serve as the Commonwealth's primary hub for healthcare data and analytics, and to objectively report on the Massachusetts healthcare system. CHIA collects and manages some of the largest healthcare data assets in the state, including the Massachusetts APCD, our hospital discharge database, and provider financial performance data. Our reporting ranges from broad assessments of overall health system performance and statewide healthcare spending to more targeted analyses such as hospital readmissions. So I will get on to the first use case, which also started in 2012, and the same legislation that founded CHIA, Massachusetts also enacted cost containment procedures that would include monitoring total medical expenses, or TME, for managing provider groups based on Massachusetts residents. And under this legislation, provider groups with total medical expense growth that exceeds our state's cost growth benchmark could be subject to a performance improvement plan. Because providers are held accountable for their TME growth, it's especially important to correctly attribute spending to the correct provider organizations. Excessive cost growth is assessed at the payer-provider contract level. So we rely on the health plans, which I'll also call payers, to accurately attribute individual clinicians to larger provider groups. This information is collected in summary format, in which payers are asked to aggregate their spending based on members assigned or attributed PCPs, and then report at the provider group level, which may be a large parent organization or a smaller local practice group, depending on how that payer contracts. That means that some provider groups are going to be reported at multiple levels within our data sets. And we've learned to live with that to the extent that it reflects valid contracting differences between the plans. However, we've also learned over the years that sometimes payers don't update their provider organization lists promptly, or they may not be aware of certain changes happening underneath the provider organization, at the local practice group level with affiliations. And that's why each year we give the provider groups a chance to review their own data that was submitted by the payers prior to publication. And sometimes through this process, we learn that a certain group is now part of a different organization. We feel like this verification process is essential to ensuring that our providers feel comfortable with the data used to evaluate them, and has also strengthened our credibility and goodwill among both the providers and the payers. Our second use case, in our second use case, we took a different approach to attributing individual providers to larger organizations. CHIA was tasked with developing a consumer-friendly website that would allow users to search for certain shoppable procedures by location and provider type and obtain an average price for that service. The data source for this project was our APCD. We used the servicing and billing provider NPIs submitted on the claims and linked to NPAS, which it sounds like several others are also using, to serve as a single source of truth for provider names, taxonomies, and practice addresses. As we know, data is really that simple, and many clinicians work at multiple locations and even multiple practices. So to anchor to a single provider organization, we use the servicing and billing provider information in combination to anchor the servicing providers to a single billing provider NPI based on where they had the highest claims volume during the measurement year. And so with this approach, we were able to capture the relationship between the individual providers and the larger provider organizations for the purpose of presenting retrospective prices. So those two examples both had to do with data that we were getting from the payers, but there are other kinds of data that we collect directly from the providers. And so one of those is our Massachusetts Registration of Provider Organizations program, or RPO. That's a program that we jointly administer with our sister state agency here in Massachusetts, the Health Policy Commission. And RPO provides a structured way of monitoring the evolving provider landscape. So provider organizations that meet minimum revenue or patient panel thresholds have to submit annual data to us, including corporate and contracting affiliations, physician rosters, audited financial statements, and other information. This data supports market oversight activities and is also released as a public use file that anyone can use to gain insight into Massachusetts provider affiliations and finances. One challenge we faced is that the provider market is becoming more complex due to rapid consolidation and increased private equity activity. And so understanding who owns and controls the provider organizations is essential for regulators, but we didn't always have the complete picture in our data. And in this case, the solution was policy change, which I know is not simple. But recent legislation has strengthened our authority under the RPO program to collect financial data on significant equity investors, healthcare real estate investment trusts, and management services organizations. Oops. Sorry about that. And we're hopeful that this expanded scope will allow regulators and policymakers to trace financial influence and control more accurately across the healthcare system. This is rather new. We're still in the process of standing up the new submission requirements. And we know that from past experience, whenever there's a major change in the data specifications, submitter feedback will be essential to ensuring that the data is accurate and relevant.
275.
So the Health Policy Commission has led efforts to solicit feedback from the provider community on the draft data collection templates and guidelines. And in addition to requesting broad feedback, providers were also prompted with specific questions, assessing whether they felt like this data that we were collecting would be accurate, if there were areas in the specifications where additional guidance would be needed, and whether certain nuances of their management contracts were accurately captured by our reporting materials. So I hope that these examples have been helpful to illustrate how CHIA uses provider data to promote cost growth accountability, price transparency, and market oversight in Massachusetts. I think what we've heard today is that there are many different kinds of provider data, and there's probably not one single data source that's going to answer all provider-related questions, but we've found success in leveraging different types of data depending on the use case, and above all, working closely with our stakeholders to ensure the accuracy of our results.
Okay, thank you, Ashley. If we could have all of our panelists turn on their cameras and come off mute for a second. We're going to do Q&A, and I am going to start with the queue because I haven't seen any questions come in yet. So, and this is for anybody. It doesn't have to be everybody, but anybody who wants to respond to this. I have heard mixed reviews of NPES data, and so I would maybe just be curious as to what your thoughts are on how well does NPES meet people's needs who are looking for provider data? And if there are things that need to be fixed about it, and you can wave a magic wand, what would you fix about NPES data? Like, that's my backwards way of asking you to complain about it. So it's like asking you how you would fix it. So anybody want to take a crack at that first?
I'd love to. I've taken a lot of time over the years complaining about NPES. But like I mentioned, the NPES is great as a universal data set of provider identifiers. I think that's why we use it. NPIs are all over claims data, other data sets. It kind of forms a really critical backbone for provider data. NPES itself is great as that universal list. It's also nice that it has name and some address and specialty information. Where it gets a little tricky is that, again, this goes back to sort of what's the data set's primary purpose. It's basically to get an NPI, and there's not really any enforcement of updates to NPES. So even the location, even specialty, and in some cases even name can get out of date as time goes on. It turns out that people move, and so often those moves are not captured in the practice location, for example. So that sort of dynamic over time is a key weakness of NPES. And in our work, we opt to, wherever possible, tie individual providers to a practice location address, not to the one that's listed in NPES, but to really to a type 2 NPI, an actual organization NPI. Those addresses we found are a little more stable. Buildings don't move as much as people do. They do move. Sometimes organizations will move buildings, but those addresses are a lot more stable. So when we tie individual clinicians to the organization NPIs where they're practicing, and that's where we get their address. And that ends up yielding a fairly sizable number of corrections. Specialty is another one that we've thought about tackling. You could probably do some things with claims to look at what providers are actually doing now or recently relative to what they were doing when they first applied for their NPI. And then, of course, affiliation data is not in NPES at all. You have to get that somewhere else. So that's my soapbox about NPES.
Okay. Anybody else want to complain any more about NPES? Or, I mean, that was a lot of complaining. So
sorry.
That's fine. Anybody else want to complain a little bit more, Ashley?
I mean, I would sort of co-sign. I mean, Robert, many of the things you listed are challenges that we've run into as well. And I know sometimes, I think we were doing the analysis and we found a whole like cardiology practice that was listed as veterinary medicine because probably one person input the taxonomy code incorrectly for the whole organization. And so there are challenges. I think for us, it kind of depends on what the data is going to be used for. And like, for example, when we were doing our, if we're doing market oversight activities, I think it's really important to get things absolutely accurate. But there's like real financial consequences potentially for organizations, and so that's when we would use something more specific to our needs. But for like our price transparency website, there were so many individual servicing providers in the data set that we couldn't have possibly followed up with all of them. And so NPES was a good starting ground because of the universality, as you mentioned.
I do have a comment here, and then we're going to go to the next question. This is from Andrea Clark. A former NHID colleague used to call NPES the wild, wild west. No lie was detected. So, all right. So there we go. Let's go on to Sri's question. Do you know if people are actually using the procedure pricing websites? And do you have a way of knowing about that? And she mentions that, of course, there was one in Utah that was created, but wasn't updated after the 2019 APCD, which roughly coincides with about the time I left. So I know that we had concerns about that. It was taking a lot of energy, a lot of effort to create these things, and we're not really sure if anybody's using them. So Ashley,
Yeah,
your mic's still on. Go ahead.
Yeah, that's a really excellent question. So as a starting point for answering that question, I'll say that with the legislation that founded CHIA in 2012 also tasked us with creating and maintaining a cost transparency website for consumers. And so that is something that we have continued to do. I think there are, we've also tried to make sure that's not the only price information that we're putting out into the world. And there may be other metrics that are more impactful for policymakers to consider. And so we try to provide a variety of, cost and spending data so that everyone has information at a level that's appropriate for what they're trying to do with it. Because I agree that consumer websites are not the be all end all of controlling healthcare costs.
Yeah, that was kind of my opinion is that while policymakers, of which I am one, think about if we could just provide consumers information to make healthcare shoppable, it would be more competitive and it would drive efficiencies and it would do a lot of good things. The reality is that is a lot harder to do in practice than it is in policy. So it is a tough thing. Let's go to this other question that was sent to me separately. So how do you deal with provider group disputes during review? Specifically, what do you do when providers say that you have grouped them incorrectly? Do you have a verification process, validation process? How does that work? And Jillian and Angela, you guys haven't had a chance to answer a question yet. So I'd like, if you want to go first, we'd love to have you go first, either one of you.
I mean, when providers come to us for a report that we have specifically created, we will adjust it on our end. And again, footnotes are your best friend, so we will footnote it as such. But that doesn't happen too often for us here in Virginia.
Yeah, we don't actually do the grouping. They tell us they're grouping. So they'll register as an individual provider and then also as part of a group. So it's pretty much their responsibility to put themselves in the correct place.
Yes, perfect. All right. Well, we don't have any other questions that have come in from the group yet. So let's go ahead and ask another question from my playbook here. So I did want to ask you, maybe Angela, this is probably more for you, following up on federal requirements. How should I think about that? Like, what's the point? Is it working? How do you feel about this whole idea that there are in fact these requirements?
Oh gosh, what a philosophical question for me now to answer. I think the provider dashboard is a great idea. All of the MCOs have their own and they all work very differently. And I think it's nice to have a single source of a directory for the Medicaid members in Kentucky. So I appreciate that. I do like the idea that we don't have to include them if they haven't seen a patient in any capacity, whether billing, providing, prescribing, referring. If we don't see them in our data at all, our claims data at all, they just don't make it onto the dashboard. And I think that's useful information for the Medicaid members. As far as keeping up with the requirements, there are that's going to be interesting, because there's also a requirement that we're supposed to have an API that transmits the data to the MCOs. So we haven't, I'm not sure how that particular task is coming along yet. We weren't involved in that one. So I'm not really sure what they're going to do with that. Is there going to be some sort of reconciliation between Medicaid and the MCOs or not? Because oftentimes we get data in from the MCOs, like this is our list of panel providers, and it doesn't match ours at all.
Okay. Anyone else want to jump in on that one? I do have another question that has come in, so. No, okay. Let's go to this one. So Robert mentioned name updates being a problem in NPES, and then Jillian in her presentation talked about provider name standardization. How much variability over time should we expect to see in providers' names? And is that really a people name problem, or is that more of a corporate name problem, or can it be both? Jillian, you want to go tell us your thoughts?
I would hope that there would not be that much variability over time. I mean, if anything, there were a lot of issues that we noticed in the beginning, because there was a time when I had first started that we were not linking to NPES at all to get name information. And so we were having to do a lot of name standardization exercises. But now that we have sort of been like linking to the NPES to at least get like that baseline of names, it has helped a lot.
So, sorry, go ahead.
I was going to say, I mean, I agree. NPES is helpful because the providers are responsible for updating it. So if the name is out of date, at least it's on the providers, and they're the ones who can control it. But we have seen we've had a lot of market acquisitions, providers changing affiliations from one larger parent company to another, and so that's where it's helpful to have the registration of provider organizations that we do, where they're updating us each year on how all those contracting entities are affiliated and what their current naming structure is.
Sorry,
Yeah, go ahead. No, go ahead.
Yeah, so I was going to say on names, yeah, echoing what Jillian and Ashley said, that it is on the providers to update those names, and with the organizations in particular, you do see obviously there's a lot of mergers and acquisitions and that kind of activity. A lot of times in NPES, what I've seen is certainly the legal name often does not get updated for the entities. Sometimes the DBA name that Jillian pointed out, the doing business as name, will be updated, or an additional one will be added. They actually just switched in NPES. They just switched that from a single other name to now there's multiple other potential names for the providers. So that's a new sort of structural challenge to deal with. But so some of those name changes do happen, but you will see one that comes to mind is you'll get some states where there are public hospital districts, and that'll be in the name. But if you look at what that hospital actually is, there's some more recognizable name on the building. Whether that is reflected in NPES is, I've seen it both ways. Sometimes it's there, sometimes it's not. With individuals, you don't get too many name changes there, but you do run into the case where someone will get married and change their last name, and so those situations do happen, and there is a way in NPES to see a former name. If that is provided, it's on the providers to put that information into NPES, and it is there for those that do put it in, but hard to say how complete that is.
Okay. We've got one follow-up for Ashley from Chia, and then we're going to have you all give your thoughts on the concluding question. So what feedback has Chia heard from providers about expanded RPO data collection requirements? And then we're going to go around Jillian, Angela, Robert, and back to Ashley on the concluding question. What's the biggest unsolved provider data problem that would benefit from some form of multi-state collaboration. So think about, is there a problem that is a big problem that we could solve if we all got together? So, okay, go ahead, Ashley, and then we'll go around for that one.
Sure. My answer to the provider feedback question is a bit boring because the data specification review period has just ended. I believe it was yesterday or possibly today. So we haven't had a chance to consolidate and review all the feedback yet. I will say that we in the Health Policy Commission work very closely with our stakeholder groups here in Massachusetts, including the various provider groups. And so we have had a good relationship with them historically, and they have provided a lot of helpful feedback on whether the questions that we're asking are likely to yield the answers we're looking for. So I'm really hopeful that whatever responses we get are going to make the data collection that much better, but we haven't had a chance to review yet.
Okay, great. Now for this go around the horn on the big problem that still exists, but we could actually solve.
I think ultimately it's just the lack of standardized provider data. I mean, as Rob mentioned, there's all these fragmented data sources out there and they all have a different purpose. So if we could come together and pull out, key elements that are most important to us and develop that like one-stop shop that had everything, that would be ideal.
I think I was next. I'll just say, Jillian took the words right out of my mouth. I think, yeah, provider identity and being able to reliably identify providers and tie them to current information is a key thing. NPES is it's got everyone that's ever been in the system. Sometimes it's hard to say from NPES who's still actively providing care. Things change over time. I think that provider identity and sort of keeping up on that in a standard, consistent format is a huge challenge that would benefit from collaboration.
I think I was next. I'm going to say yes, that would be great, but also I think there could be some advancement in network adequacy and understanding border states and how those providers are being used by individual states. Because for us, and interestingly, I think we're surrounded by like 7 states, and they go everywhere, right? But while we can see them going there, I don't really understand those providers' usage of their own states members, right? So how many people are they seeing? Is Kentucky overburdening a certain area because they're crossing state borders and we can't see what those providers are doing?
Yeah, very good point. Ashley?
I would say like the data accuracy that Robert mentioned is top of mind for me as well, and having a way to maintain a more accurate, up-to-date information would be really critical for us. And then I think also just understanding, there are some large multi-state provider organizations and we have limited, and we can see what's happening in Massachusetts. And increasingly with this new legislation, we get more financial insights into out-of-state parent corporations as well. But it would be great to have sort of shared definitions for how we're collecting provider data, especially financial data, and how we share that across state lines.
All right, fabulous. Thank you. Well, thank you all 4 of you for taking the time to prepare and present such great information. Just in case you were wondering, we topped out at just over 190 participants in today's meeting. So that's fantastic attendance. And as mentioned in the chat, all of the Hot Topics webinars will appear on the NAHDO YouTube channel. It usually takes us less than 24 hours to get those posted, but we did put the link there where you can see many of our webinars and key information. So thank you all. We will see you all again in a couple of months for our next Hot Topics webinar. Charles, you want to go ahead and end the recording, and we will go ahead and close out our meeting.